Okay, so we will discuss about the syndrome of inappropriate antidiuretic hormone. Okay, in this, first of all, we will see the diagnosis. Now, syndrome of SIADH is characterized by euvolemic hypoosmolar hyponatremia in context for low serum osmolality, hypoosmolar hyponatremia. Osmolality will be decreased and sodium will be decreased in context of the low serum osmolality less than 275 milliosmol per kg. Then urine osmolality will be greater than 100 milliosmol per kg, and the urine sodium will be greater than 30 millimole per liter. Okay, serum osmolality will be decreased, urine osmolality will be high, and the urine sodium will be also high. Now, okay, SIADH can only be diagnosed after the exclusion of hypothyroidism. Okay, SIADH can only be diagnosed after the exclusion of the hypothyroidism. If there is no hypothyroidism, then only SIADH can be there. Total salt depletion and the ACTH, hypothyroidism, then total salt depletion and ACTH deficiency. Okay, ACTH deficiency appears identical to SIADH because it causes the reduced excretion of free water. It causes reduced excretion of the free water because cortisol deficiency leads to increase EDH activity. Okay, this is different from hyponatremia caused by mineralocorticoid deficiency in Addison's disease. Okay, this different from hyponatremia caused by mineralocorticoid deficiency in the Addison's disease. Which are the causes of the SIADH? So the potential cause of SIADH are vast, including malignancy, then neurological, pulmonary, drugs, and miscellaneous. Okay, the causes of the SIADH are in malignancy. There is the lung lymphoma, then GIT, pancreatic malignancy, or genitourinary malignancy. Then in neurological, malignancy, infection, trauma, and hemorrhage. Then in the pulmonary, there is the pneumonia, TB, abscess, and malignancy. And in the drugs, selective serotonin receptor inhibitors, then the tricyclic antidepressant and the anticonvulsant. Then miscellaneous, there is the idiopathic HIV, MS, then Guillain-Barré, and the acute intermittent porphyria, and idiopathic SIADH is diagnosis of exclusion. Okay, so as we have seen here, in the SIADH there is the low serum osmolality, high urine osmolality, and the high sodium urinary output. Okay, SIADH is only there if there is no hypothyroidism, no total salt depletion, and no ACTH deficiency. Because in the ACTH deficiency, it identical to SIADH, same as SIADH, because it causes reduced excretion of the there is reduced excretion of the free water, and because cortisol deficiency leads to increased ADH activity, and due to cortisol deficiency in the ACTH will increase the ADH activity. Okay, and will cause the SIADH like effect. Okay, this differ from the hyponatremia caused by mineralocorticoid deficiency in the Addison's disease. In the Addison's disease, there is the hyponatremia will be there. Okay, then causes. So the potential causes of the SIADH are the malignancy of so many systems like lung, lymphoma, GIT, pancreas, and the right to urinary malignancy, then neurological malignancy, infection and trauma and hemorrhage, then pulmonary, pneumonia, TB, abscess or malignancy, then drugs like selective serotonin receptor inhibitors, and tricyclic antidepressant, and the anticonvulsant, and the miscellaneous are the idiopathic HIV, mitral stenosis, Guillain-Barré, and the acute intermittent porphyria. Okay, then management, reversal or treatment of the cause of the SIADH and fluid restriction are the key aspect of the management. Okay, reversal, we can do the reversal of the SIADH or the treatment of the cause of the SIADH and the fluid restriction. Okay, we have to stop giving fluid to the patient. Okay, these are the management including management of the SIADH. Strict fluid restriction, 1 to 1.5 liter per day only is poorly tolerated and difficult to achieve. Okay, drug treatment of SIADH includes the uh, demeclocycline and ADH antagonist. Okay, demeclocycline and the ADH antagonist. Okay, demeclocycline reduces renal response to ADH, but its use is limited by the side effects. Demeclocycline reduces renal response to ADH. Okay, demeclocycline and the ADH antagonist are the management of choice. Demeclocycline reduces the renal response to the ADH. Okay, reduces the renal response to ADH, but its use is limited by side effects and unpredictable pharmacokinetics. ADH antagonists directly block the ADH action, and are of use in specific clinical situation. Okay, we can give the demeclocycline, but its use is very limited because of its different side effects, and ADH antagonist will block the ADH action, and its use is there in the specific condition. Okay, now we will discuss about the thyroid function. Okay, so thyroid, what is the function of thyroid? So anatomical, we will start with the anatomical location of the thyroid. Okay, so the thyroid gland is attached to the anterior surface of the trachea. Okay, anterior surface of the trachea, just below the larynx. Okay, just below the larynx there is the on the anterior surface of the trachea, the thyroid gland is located. It has a right and left lobe joined by a central isthmus. Okay, it has a right and left lobe. Okay, this is the right and left lobe which is joined by the isthmus centrally. Thyroid lesion can be distinguished from other neck lumps. Okay, thyroid lesion can be. Okay, we will discuss in the later video.